Hello, my name is Katherine Holste, and I am a neurosurgery resident at the University of Michigan. In this chapter on treatment of intractable vertigo, we will review the differential diagnosis, medical treatment, and surgical management of vertigo. Vertigo is the illusory sensation of rotational or translational movement. Although uncommonly treated by neurosurgeons, vertigo is a very common symptom reported by patients undergoing neurosurgical evaluation. Vestibular disorders are classified as central or peripheral. Central disorders involve pathological changes within the brainstem or cerebellum, while peripheral disorders involve the labyrinth or vestibular nerve. Central vestibular disorders, which are typically insidious in onset and characterized by initially mild symptoms, arise from vertebrovascular insufficiency, migraine, tumors, paraneoplastic syndromes, and demyelinating disorders. Peripheral vestibular disorders are typically sudden onset and diminish with severity with central compensation. These include benign paroxysmal positional vertigo, or BPPV, Meniere's disease, labyrinthitis, vestibular neuritis, paralymphatic fistula, and superior semicircular canal dehiscence syndrome. An important etiology of vertigo, which may be either peripheral or central in origin, is trauma. Non-surgical therapeutic modalities include vestibular rehabilitation, canalith repositioning maneuvers, sometimes known as the Epley maneuver, and a broad range of pharmacologic agents designed to suppress vestibular input to the central nervous system. Vestibular rehabilitation maneuvers are most effective for patients with stable unilateral lesions producing peripheral vestibular disorders. By contrast, central disorders require longer treatment periods and have poorer outcomes. BPPV, which is due to otoconal debris in the semicircular canal, can be promptly and effectively treated with a series of canalith repositioning maneuvers, although recurrence is common and spontaneous resolution of symptoms is also possible. Pharmacological therapy for vertigo is directed towards the suppression of dysfunctional vestibular afferent impulses to the central nervous system. Medications including benzodiazepines, antihistamines, and anticholinergic agents are most often employed in the treatment of vertigo. These agents are most often utilized to reduce the intensity of vertiginous spells and are of little prophylactic benefit. Patients who are unsuccessfully treated with conservative and pharmacological therapies may be candidates for surgical intervention. Critical determinants of surgical success include appropriate patient selection, correct identification and lateralization of pathology, and accurate assessment of the degree of central compensation. Specific surgical therapies have been developed for several pathologic processes resulting in vertigo, including BPPV, SSCD, PLF, and Meniere's disease. BPPV most often resolves spontaneously or with application of the Epley maneuver. However, in rare circumstances, singular neurectomy, or the surgical transection of the posterior ampullary nerve, or posterior semicircular canal inclusion, which renders the copula unresponsive to angular acceleration, may be indicated for debilitating symptoms. Of the two approaches, canal occlusion appears to be the safer approach to treat otherwise intractable BPPV. SSCD results from thinning of the squamous temporal bone, leading to shunting of acoustic energy to the vestibular system. Patients with SSCD exhibit noise-induced dizziness and eye movements, or the Tullio phenomenon, and eye movement in response to pressure impulses in the external auditory canal, which is the Henenberg sign. Thin section temporal bone CT can be diagnostic for SSCD. Surgery for SSCD ranges from minimally invasive tympanostomy tube placement to craniotomy with plugging of the defect. PLF is an abnormal connection between the fluid-filled inner ear and the air-filled tympanic cavity. The diagnosis remains controversial, and it is often difficult to identify a definite site of leakage. PLF may be associated with middle ear injury or surgery, in addition to barotrauma. Although non-surgical therapies are much preferred, PLF may be successfully treated with patching of the oval or round window. Medically refractory Meniere's disease is the most common indication for vestibular surgery, even though 70 to 90% of patients respond to medical therapy. Meniere's disease is a common cause of acute recurring episodic vertigo, but the pathogenesis remains unknown. Interventions for Meniere's disease include intratympanic injection of gentamicin or dexamethasone, and the lymphatic sac surgery and vestibular ablation. Vestibular ablation entails either hearing-preserving vestibular neurectomy or obliterative labyrinthectomy. Selective vestibular neurectomy was revitalized in the 1930s by Dandy and Mackenzie and may be accomplished through the middle fossa, retrolabyrinthine, or retrosigmoid surgical approach to the 8th cranial nerve, with a published success rate of over 94%. There are proponents to each approach, and the exact numbers in regards to risk of each complication varies based off the dataset. The middle fossa approach is extradural, and therefore the risk of CSF leak is much smaller, but the risk of hearing loss and facial nerve paralysis are much higher than the retrolabyrinthine or retrosigmoid approaches. Risk of CSF leak and incomplete sectioning is much higher in the retrolabyrinthine and retrosigmoid approaches. In conclusion, intractable vertigo remains an important treatment challenge in neurosurgery and neurotology. While the majority of patients with vertigo may be successfully treated with vestibular rehabilitation and pharmacological approaches, some may benefit from surgery. In these cases, careful patient selection, correct identification and lateralization of pathology, and the choice of surgical approach are the primary determinants of treatment success.